Please excuse our preamble. Ladies and gentlemen, boys and girls, everybody, welcome to the 4th annual Health Informatics Conference at the New York Academy of Medicine. We're very happy that you're able to join us. We'll introduce the panelists in a little bit. But first, I just want to say a few things about the conference, a little bit about the New York Academy of Medicine, and a little bit of housekeeping tips. So first of all, the New York Academy of Medicine tackles barriers that prevent every individual from living a healthy life. So informatics is a large, well, it's part of that. Informatics is a large part of healthcare these days. So we do have this informatics group, and the informatics group consists of hardworking people who through the years have helped to put on these events. And so we're very grateful for all the hard work that they put into this. We're very grateful for the New York Academy of Medicine. Thank you very much for all the support that you've given us throughout the years. So myself, my name is Keith Weiner. So I am the chair of this work group, and I am your moderator along with Olga Kagan. And so I'm the chair, but we do have quite a number of folks that work through this. So I'll talk a little bit about the panelists in a moment. So this format is really part of our new normal because historically we've had in-person events and the food is awesome. The library is quite a sight to see. The New York Academy of Medicine is quite a majestic organization, building, everything else. So this is really part of our new normal. We've usually had innovation expositions where innovators were able to show a little bit about their inventions, and we're going to do something a little bit differently. We're going to have panelists discuss innovations. So we were closed for 2020 because our event was happening just shortly after the shutdown. So I'd also like to say thanks to all the audience out there
and those of you at home who have joined us. And also, I just wanted to make
it is not being sponsored. However, I did want to say a quick thanks to our sponsors from past years. Thank you very much, and we look forward to having your support again in the future. So just a quick plug to NYAM is this is one of many events that NYAM hosts throughout the year. And so I'd encourage everyone to check out the NYAM website.
Events. And you know, sign up for those events.
Use the QA function because we encourage you to ask questions, and we'll do our best to answer those questions throughout the event and after and following the event. So how to use this? So throughout the program, we encourage you to ask questions by entering them into the QA box. So if you click on the icon at the bottom of your screen labeled Q&A, you could type your questions into the box and we'll receive them. A moderator will be reviewing, that's Olga Kagan, will be reviewing questions as they come in. And during the discussion, we will pose as many questions as we can to our panelists. We'll answer as many questions as time permits. For our guests who would like to enable closed captioning, please click on the icon on the bottom of your screen labeled CC. A live transcript will appear on your feed. Okay, so I'd like to introduce our esteemed panelists. So I'd also refer you to their website for their bios if you want more information. Also, all of these folks are on LinkedIn. So if you want to see a little bit more about their background, I'd encourage you to look at their LinkedIn. So first up, I would like to just introduce our first panelist. Rebecca Love is the founder and president of the Society of Nurse Scientists, Innovators, Entrepreneurs, and Leaders. Our next panelist is Christine Monkhouse. She is the CEO and founder of Patient Orator. Kelly O'Neill is a nurse informaticist for Mount Sinai Morningside. Nicholas Soulakis is the Chief Informatics Public Health Advisor for the Chicago Department of Health. And Mikhail Varshovsky, also known as Dr. Mike, is a board-certified family medicine physician and content creator. I guess now I'm Dr. Keith and we have Dr. Olga. So Dr. Mike and everybody else, welcome. we're going to have questions for discussions. We want to keep this relatively fast-paced, but please feel free to speak up. I'll pose a question to all of you, and sometimes one of you in particular, and feel free to be able to mix in a little bit. So first up, and this is a question that I like to pose to Christine, and this really speaks to sort of the mission of NYAM. So the pandemic has shined a giant spotlight on disparities in health and healthcare. Given the acceleration of healthcare technology adoption and the emergence of new innovation to address the pandemic, what opportunities and challenges do you see as necessary for innovation focused particularly on health equity during and beyond the pandemic? And I pose this question first to Christine.
Thank you so much for having me, and thank you for that question. I'd like to start by saying that pre-COVID, healthcare disparities existed. We know that racial and ethnic inequities existed within the healthcare ecosystem. And based on where a person lived, their age, their gender, their zip code, their education level, and their income, that ultimately determines their ability to access health equitably, or to even gain access to healthcare. With COVID-19, what's happened with telemedicine and digital health is that we've quickly shifted to adoption, which means that some of those issues that I just stated before were no longer an issue in some regards. So for example, if a person doesn't have the means, the transportation to get to their health appointment, now we have telemedicine where a person could be in their home and access their appointment directly from the comfort of their homes. But on the flip side of that, there's been a number of barriers that have been illuminated, so to speak. And the first is with the digital divide, where not all Americans have access to broadband internet. And so what about those folks that can't access telemedicine in that same way? I think secondly, the cost, again, going back to the fact that not everyone have access to a smartphone or any kind of smart device. So that leaves a gap there that needs to be addressed. Then there's literacy. And in regards to the issue of literacy, there's two levels. First, the level of education, what level of education a person has. And second being the level of literacy a person or knowledge that a person have to with using technology to address, to access their health appointment. And so those are some of the barriers on a very high level, but then we go to this issue of privacy, whereas before the doctor-patient relationship was very sacred. And one of the things that we kind of took for granted, I think, is the fact that there is a certain level of confidentiality and what is discussed in that health appointment really remains there. With technology, and especially with lower income Americans and communities, we now have the doctor coming into the patient home where they might be sharing a space with a number of other individuals. So their ability to speak freely might be limited. And so those are some of the hindrances that we see from an equity standpoint. I recently had the opportunity to speak with an MD who works in an FQHC, and their patients predominantly are high-risk moms of color. And what she shared is that they are seeing, now that the COVID-19 restrictions in terms of social gathering are lifted, is that there's a preference for in-person visit as opposed to virtual visits. So those are some of the things that from a challenge standpoint that we're seeing. And then the opportunity, I think, is what those challenges highlight is there's a great need for public and private collaboration, for inclusion of the patient voice, for inclusion of community health workers and other people a part of that patient's eco care system, so to speak. And I think until everyone has access to telemedicine equitably, there's still a lot of work needs to be done.
Excuse me, I was on mute and I realized that not everyone could read lips. Thank you very much. That was really awesome. I really do appreciate your insight into that information. I'm sure our audience does as well. Does anybody else, in terms of equity, does anybody else have anything else that they would like to add that's on the panel? Just regard to the pandemic shining a giant spotlight with the adoption of technology and how this affects health equity during and beyond the pandemic.
I actually have a thought process on this. Recently, I put together a panel for back to school conferences on behalf of the Biden administration with some of those in attendance. And what became very apparent to me was the role that school nurses have on addressing health equities across the nation. If there's one place that healthcare can be accessed, it's through schools. And what was shocking to me was that how many schools in the United States do not have a school nurse on hand. And what you find is, especially as we've been reopening schools at such a rate, and we're really experimenting with schools first to trying to reopen society, how effective school nurses were at actually controlling that pandemic. And in an interesting point of view, in 1918, when the pandemic hit, that first one back in the Spanish flu, it was in 1920 that New York City tried to reopen up all of their schools, and they weren't effective at doing that until they put a nurse in every single school in New York City to be really effective. So if you want to address health disparities at an equal one, putting a school nurse in every single school across the United States could be a really good way at addressing health disparities and accessing to our most critical population, which is that next generation coming forward. And I think if there's been one thing that's been put in place, accessing and providing that kind of level of care, and school nurses being on the front line of that, could really start addressing health inequalities and disparities in communities across the United States in a way that most other public health has been inefficient or unsuccessful at doing.
Okay. Okay, that's quite fascinating, and yes.
Could I add to that, Keith?
Please do. Yes, we'd love it.
Sure. Thanks everyone for your time and attention today. So I'm a contractor at the Chicago Department of Public Health, and in Chicago, we have a very strong emphasis on equity and hyper-local interventions. We operate under the banner of Protect Chicago Plus, meaning that we identify our most vulnerable areas of the city, and we make sure that all of our interventions are suitable in our most needy parts of the city. And one of the things that I've recognized is that hyper local is worth doing, of course, because this is where we see the dips in performance. These are the hardest populations to reach. But one thing that I've recognized is that we get very excited about identifying partners for our hyperlocal interventions. And I'm sure this is true in a lot of urban areas. But one thing we do is we forget that they were the least resourced to begin with, usually. That we don't recognize that the gap we have our tech partners that we work with on a regular basis that do, let's just say our citywide interventions. But then when we go to award, funding and contracts and grants at the hyper local level, we hold those partners to the same standard, which there's a reason why these populations are underserved to begin with. And so if that didn't exist to begin with, it's a very large ask. So we're not setting our partners up for success. So, I would say that as we address equity, we have to also address the infrastructure and capabilities of equity partners when we do these hyper local interventions. And there's a reason why they are not, they don't have the same capabilities as our academic medical center partners, for instance, large teams, large resources, depth of expertise. So I would just say that we make sure that we bring up our tech partners when we do these hyperlocal interventions, and we don't drop our expectations. The expectations are the same, but we raise our expectations of the infrastructure and resources that we need to bear for a complete intervention.
Okay, fantastic. Thank you for that perspective as well. And would anybody else like to opine on this? Okay, so the next, thank you very much. The next question that we have, I'd like to direct to Dr. Mike. But before I do that, I just want to say that the QA chat actually shows a fan base. So your fan club is there. So people want to say things like they're inspired by you, and they would love to personally tell you about that, how much that they inspire you. So you bring with you fans. I'm an actual rock star, but I don't get fans like this. So this is really awesome. So this question is for Dr. Mike. Amidst the pandemic, we have seen more and more physicians embrace telemedicine. So for many doctors, this is an entirely new phenomenon, or at least the extent of which is an entirely new phenomenon. Some of you have been on the other end of the screen for quite a while now. Some of you, like Dr. Mike, for example, even have millions of viewers looking on. So what are some helpful tips for both doctors and patients alike that might help them with these new type of FaceTime kind of phenomenon visits?
Yeah, thanks, Keith, for that kind introduction. Shout out to all the people watching who subscribe to the YouTube channel. Thanks for coming by. I think it's really important to both celebrate, but also critique telemedicine as a whole, because it certainly has amazing benefits for the times like we've been experiencing with the pandemic, where barriers to care have greatly expanded outside of the inequities that have always plagued our healthcare system. Now getting to see your doctor became even more difficult or even dangerous in some cases. So telemedicine did a great job in trying to fill the gaps in some of those instances. However, being a family medicine doctor, I've now experienced working in telemedicine over this last year and have run into a lot of troubles. There is no physical exam that happens during a telemedicine visit. So while I can perhaps make some changes to insulin management for diabetic patients, or for diagnosing some rashes that I can make a visualization on, a lot of medicine is really hands-on, using the stethoscope that we carry around our necks that actually serve a purpose. Finding out where a patient has pain, what level of pain they have. Is it on deep palpation or light palpation? Looking inside a young child's ears to see if they have an inner ear or middle ear infection. So telemedicine certainly has a lot of benefits in order to help patients who have barriers to transportation or distance to see a subspecialist. But there's also true hesitations and limitations that exist that we need to be talking about, and not just saying telemedicine is the future, it's going to solve all our problems. It's not. And there's certainly benefits that we need to lean into. There's also super shortcomings. And one of those major shortcomings we sort of touched on when we mentioned the inequities is tech literacy. You know, some of us may not have access to broadband, true, but then some of us have access to broadband but have no idea how to use it. And I've seen that in my senior citizen population who unfortunately skipped the whole telemedicine aspect and asked me to give them a phone call instead of seeing them virtually because they don't know how to make use of it. So I think we have a long ways to go in making telemedicine the norm when it comes to making these long distance visits. And also not lose sight of the fact that the best visit, the one that gives you the most reward, that gives you the most benefit to the doctor-patient relationship, is the one that happens in person.
Okay, well, thank you very much for your perspective as a physician and as a YouTube channel content creator. So just does anybody else want to opine on telemedicine? Because this is something that happened rather suddenly, and the emergence of which has become rather pervasive. Yes, Kelly. Hi, Kelly.
Yes, hi. Hello. So I'm a mother of two. I have a 12-year-old and a 1.5-year-old. And I had to engage with telemedicine as a mom with the baby. And it's very hard because when you use your phone or the computer, the cameras didn't reverse. So it was very hard to show the doctor exactly what was going on. And they just kind of, not that they guessed, but they said, oh, this is probably it. They weren't doing in-person visits. So it's very frustrating as a parent, telemedicine, you know.
Okay. If you don't mind my asking, and I'm kind of putting you on the spot, so please excuse me for this, but I understand that at your institution at Mount Sinai that there was quite a lot of innovations in terms of cameras monitoring patients. I don't know if you've been involved in that or had any exposure to that, or would like to tell us anything about some of those things, because in a way it's kind of telemedicine in a way, even though you're outstanding outside the door.
Right. So we implemented, we worked with Google and we implemented Google Nest. So basically our med-surg units became ICU units. And in a normal med-surg unit, the doors don't have windows, so you can't see in and you can't see the patient. They're on a ventilator, you can't hear the alarms, you can't hear the bedside monitor beep. So we installed Google Nest cameras, 2 cameras on each patient, one to watch the monitor and the second one to watch the patient. And then we connected it to iPads outside the room so the nurses could see both the bedside monitor and the patient, and, and just walk the hallways and check in on all their patients. It was really cool. It saved, time for the nurses donning and doffing, going in and out, in and out. It also preserved PPE. It was,
okay.
quite incredible.
quite incredible. And ultimately, I can imagine it must have saved lives. So that's really fascinating.
Yes.
Thank you. Thank you very much. So that's an example of some quick innovation using consumer technology, you know, for health purposes. That's fantastic. Would anybody else like to, and thank you very much for sharing your personal experience as well. Would anybody else like to opine on telehealth?
Keith, I know I actually didn't address one of the questions you mentioned in your question, where you said, what tips do I have for physicians and patients alike when it comes to telemedicine visits? And I think in thinking about it, one of the good points that I've heard made before is one of the most important things to have a successful telemedicine encounter is to triage them properly. So when a patient calls my office and they say they have an issue with abdominal pain, that is in essence a visit that should take place in person, because that requires a proper physical exam. But like I mentioned earlier, if you have a patient with a rash or perhaps a question about their medication, that is absolutely one that can be done virtually. So I think triage is probably one of the most important focus points that needs to take place with telemedicine. And when it comes to patients, going in with as much information about your condition and questions that you've done research on before scheduling your appointment is beneficial, whether it's virtual or not. Also expect technical glitches and errors and being able to sort of adapt as you go, because while this is technology that has been around for a while, the video conferencing technology, the way we're using it in hospital systems to keep it secure, to make sure that we're able to connect with patients rapidly, there's always things that make it a little bit adaptive needy, if you will.
Right. Okay. That's really good advice. Thank you very much for that, and thanks for jumping back in there. I mean, I do know at the run up of this the pandemic originally, and people had to do a quick about face as to how they would communicate with their physician. Things such as FaceTime, Facebook Messenger, all kinds of things were used, and I know that the feds kind of sort of were relaxed about enforcement with that. Okay, so the next question, unless anybody would like to opine further on the telemedicine aspect, next question.
If you don't mind, there is actually a relevant question in the chat, which we may want to maybe ask now, as we're on a topic at the moment.
Okay, would you like to ask it?
Sure. The question is about the thoughts that we have when focusing on maintaining a holistic view and treatment of patients during the time like COVID, where we limit in-person interaction. So if anybody wants to take that.
I'll jump in.
Thank you.
And I think that telemedicine, one thing about telemedicine, it's very convenient, right? And so for friends of mine, I'm a mother too. For a lot of us that were home, using a telemedicine visit actually was quite convenient for us. But what we started to find is that, to Dr. Mike's point, telemedicine in and of itself didn't necessarily drive outcomes. And so I think when you're looking back at the world of payers, which want to see this interaction leads to this kind of outcome, we recognize that telemedicine is probably at risk from the payer's perspective to continue being reimbursed at large amounts. Now, I think in regards to that, the difference between telemedicine and remote patient monitoring with regards to chronic disease states or specific disease states has actually showed to be highly effective. Diabetes management, congestive heart failure management, especially when you were supported by tracking of data that could be monitored on an ongoing basis in a way that most of us who've ever done face-to-face visits never had access to before. Because suddenly over a 3-month period, you could be uploaded an entire patient engagement program that you would never have seen before if it hadn't been for the adoption of these remote patient monitoring systems. So do I think that telemedicine has a strong foothold? I do, but I think they're going to be tied to disease states. And the truth is, when you looked at actually the statistics, patients loved telehealth visits. Their patient satisfaction, physician interactions, they were through the roof in ways that most physician interactions or clinician interactions have never been recorded before. So from that perspective, patients loved them. Clinicians had some questions on them. And the truth is, it's still out on the jury if telehealth by itself was effective at that. So I'm happy to turn that back over to somebody else, but really interesting stuff going on there.
Yeah, wonderful. So patient satisfaction, and it's kind of a new normal for clinicians as well, and adjunct, but not necessarily in replacement of clinical care. Wonderful. Okay. Okay, so unless anybody else has anything, we'll move on to a question specifically for Nicholas. And this question is, what clinical informatics infrastructure, and for the rest of you who are not in institutions, it could be applied to things that you have seen, but what informatics infrastructure investments will you make this year, and how will those infrastructure investments scale beyond COVID? And then for those of you, those of you who are not in institutions, but just things that you see or can foresee being implemented. So with that, this question is for Nicholas.
Sure, thanks for that question. That's a good one. And I wish my answer were jetpacks, and gee whiz technology. Even Google Nest sounds really good, actually. But the truth of it is, I'm at a health department, and our problems are much more basic than that. And I'm normally, I'm on leave from Northwestern University right now for COVID response. And my colleagues, my colleagues that know me from my informatics division have a lot of really, really good ideas. It's just unfortunate that we're at such a basic level right now, you can't take advantage of them. So what do I mean? We have to process our electronic laboratories feeds, right? Both positives and negatives. It's a tremendous volume of data. Our immunization registry, we need a connection to our immunization registry. Now we're an urban jurisdiction under a state jurisdiction, the state of Illinois. So we have to have fast connections to our immunization registry. And then of course there's disease reporting itself. We have an electronic disease surveillance system for our state. All of this data going back and forth is very basic. We've had these standards and protocols for a very long time. But whereas we used to have 50 cases a month, now we have 50 cases an hour. Where we were contact tracing 2 cases, now we're contacting, 2,000 cases. And so very basic things, that file server that all your epidemiologists are on, those laptops that are 6 years old, the software that you're using for visualization doesn't handle the size sets anymore. All of these things are, when I came in, were ripe for a cloud infrastructure. And so some of the most basic things we did was we have very experienced epidemiologists, 20 years at the department, that are actually watching a status bar for 3 hours on a program run, because they're on an old laptop connected to an old network looking for an old file server. Whereas if we can, what we've done is we've moved our software to the cloud. So we've gone from, we use lots of different softwares, but I'll just use SAS as an example. There's SAS for your laptop, there's SAS for the cloud. We've moved to a clustered server-based SAS. So all of our epidemiologists who are used to using it can now simply open a browser. We have huge turnover right now. We have lots of contractors across the entire department. We can't wait for them to get a laptop, get it imaged, get it VPN so that they can access, right? So having virtual machines from the cloud has really been tremendously helpful in getting people up on day, as soon as they have their Active Directory credentials, or excuse me, their login for the health department, they're able to log into that infrastructure and start their session, start their SAS programming right then and there. So that's some things we've done. So the time to processing goes down. And then it's not nothing, but I distinctly remember our head of epidemiology for our COVID response bureau. We were importing a file. We were chatting, and I said, I'm going to go ahead and kick this off now. Let's touch base when it's over. Before I could get off the couch, it was over. And we both had this moment where we realized we were going to have a lot more time on our hands. And it all was worth it at that point. We realized that not only is this faster so that the programs are running faster, it frees up time for your most experienced people to be doing other things, making other decisions, exerting their expertise in other areas of the response. And so it's very basic, but actually just processing your data, moving to a cloud, it was not trivial. We had some, luckily Chicago had some experience in cloud. It wasn't all new. So we were able to leverage some existing accounts. We started outside of our City of Chicago tenant. We moved inside the City of Chicago. So in general, cloud was one of our biggest investments. And I'll just close up by saying that when when I came in September, I'd been working at the state for a while. When I came in September, one of the first things I recognized was that we had a lot of seasoned expertise in the building that we were going to need. And so the tool needed to work for them. I, of course, am a professor of informatics. I know all the gee whiz tools. We would lose our most seasoned veterans if we tried to move everyone to brand new tools. So we just doubled down on the tools that were in the house already that people were really good at, and packaged it as a growth opportunity. That thing you already know, it's just going to be in a different place. It's going to be in the cloud, right? And people appreciated that we recognized their expertise, their hard-fought professional wins, in all of the, even since, for a lot of public health crises. So, and I'll just wrap up by saying, never has it been more true that every single piece of data we collect has a cost associated with processing, analysis, reporting, responding to it. And I must say this 10 times a week, but we don't monitor what we can't respond to. There's just too great of a cost. So when a program comes to us and says, hey, we have this great new infrastructure we've invested in, let's use it. My next question is, well, what are you going to do with that information, right? And so putting in a simple screen when we're all sort of flush with cash and there's lots of toys to buy, I don't think our principles of public health practice should change, that we still need to ask these questions and not be enamored with new technologies. And with that, I'll—
Wonderful. Okay, well, that's wonderful. So it sounds to me like, and by the way, the jetpacks, NYAM, if you're listening, if I could expense that, I'd really appreciate it. There's a need. So parking is tough in Manhattan. So, but joking aside, it sounds to me like people, processes, technology. It sounds like you had a need to begin with, and maybe the pandemic might have been a catalyst. The public health crisis may or may not have been a catalyst. And it sounds to me like it's the things that you would have needed all along to really enhance a lot of the workflows, to really be strategically be economical with your resources and make the most of them. So really do appreciate that perspective. And sometimes it's the simplest things, just like when we were discussing about having two-way video inside a patient room rather than walking in. Some of these things are just very, very simplistic, and cloud technology seems like that's the way that the world is moving. And perhaps from my perspective, and I don't want to take the place of anyone else who wants to respond to this, but it seems like the pandemic has certainly accelerated the emergence of these new technologies. So with that being said, would anybody else like to opine on some of the innovations that you sort of see, the investments that you see in infrastructure happening this year and beyond as a result of COVID, and how it's going to scale beyond? Any panelists? Infrastructure, maybe some of the things that you're doing in your respective institutions?
I've actually seen some pretty cool advancements being made in the infrastructure, battling the issues surrounding health literacy. For example, I work frequently with the new team at YouTube Health, where they're putting a tremendous focus partnering with large clinical institutions, Cleveland Clinic, NAMI, Hopkins, and the goal has always been to deliver accurate information to the most amount of people. And as we've seen with social media, the lack of evidence-based physicians on there has led to a tremendous rise of misinformation, to the point where even in my day-to-day practice, patients are coming in confused more than ever about what's true, how much that they've read is misinformation or not. And partnering up with YouTube Health and them using their own algorithms and the information that they have from Google search, from understanding how people best understand specific bits of information. We're making huge headway into figuring out how to reach more people with accurate information, but also relatable information. And like over the last month, 28 days, I have 40 million viewers on my channel. If I can reach 40 million people with an accurate message about COVID-19 vaccinations, that's a huge win for health and public policy. So I think while it's one of the most overlooked forms of health infrastructure, I think it's a really important time for it to be focused on with this pandemic and the rise of misinformation online.
Wonderful. And thank you very much for your service to society in doing that. Okay, so there are two questions that kind of really go hand in hand. So I guess we're looking at COVID. As a result of COVID, we see a wide range of technologies to engage and monitor patients. So this is kind of really a multi-part question, right? So how do we prevent this innovation from becoming another barrier to access or an interaction, another barrier to access or interaction with provider about health conditions? So these monitoring technologies, and then I guess the other flip side of the coin of that is, when we're talking about monitoring, really, is that we see a lot of wearable fitness trackers, right? So and this is not an endorsement, Apple didn't pay me, but I live with this, with my Apple Watch. I use it for tracking all kinds of things, right? So it tells me if I haven't washed my hands for 20 seconds. There could be an O2 sensor if I upgrade it. Supposedly, rumor has it, tomorrow they'll be announcing glucose monitoring, right? It tells me my steps, how many flights, if I slept enough, if I didn't. I mean, it does everything. It's like the newfangled mood ring, right? So from counting steps to analyzing sleep and so on. So what is your take on this information on these very common devices, and how should they confer with the doctors, and what about this information do these devices tell us? Because there's a tremendous amount of innovation in the space of physiological monitoring, both inside and out of the hospital, and these watches are rather expensive, right? So this could be a barrier for some. But really, you know, if people could sort of opine on these devices, the usefulness of these devices, and how maybe some of these devices can kind of overcome some barriers, or perhaps may even cause some barriers. And maybe the question might be first to Dr. Mike.
So for me, technology innovation is exciting. Being a young doctor walking into the hospital for the first time, when it was like 10 years ago, seeing how outdated everything is was quite a shock to me. Nowadays, we're starting to make advancements, but knowing so much information isn't always a good thing. And this almost goes hand in hand with how patients expect to get 1 million tests done, thinking that more testing is always in their benefit. That's not always reality. So nowadays, with the, as you mentioned, Apple Watches, they have the EKG feature where patients get alerted if they have one episode of atrial fibrillation. And now they're getting scared because they don't know what it is. Is it a heart attack? Is something bad happening? They run to see their family medicine doctor or cardiac specialist. And the reality is, we don't know what to do with this information yet. There's so much information given to us as physicians. Our guidance comes from research, and our research wasn't done on Apple Watches. It was done on patients coming in with symptomatic atrial fibrillation, or perhaps finding it incidentally on a Holter monitor. So we don't know how to guide some of these patients based on their wearable technology because the research just hasn't been done yet. So as a result, I try and tell patients to not spend a huge sum of money of their health budget on these wearables until we have a reasonable goal or research as to what we can gain from them. You know, I see like these new ones popping up that give patients a recovery score, all these patented numbers, combining how well they slept, their heart rate variability. And the reality is it's nonsense. Like, it's someone's formula that they created that sounds really cool, visually looks amazing. But I can just talk to a patient and say, hey, how well did you sleep last night? Did you drink alcohol the night before? And I could tell them how well they've recovered. They don't need a score to keep track of that. So sometimes we're doing this technology for it just to be cool. Sometimes we're doing it with really good features in mind, but without the research behind it. So I think we have a lot of catching up to do to truly find out how beneficial this information is and to make it beneficial once we figure that step out.
Okay, awesome. That's an interesting take. So that's a physician perspective that perhaps there might be a lot of information, and that information might not be particularly telling, and that as a physician, your training and the research is actually not watch-based, right? Because these are newly innovative kind of technologies. So would anybody else like to opine on either wearable devices or physiological monitoring devices that are in the hospital? All these different data points from either consumer devices or devices that we're using in healthcare, whether it's you know, these things that look like fidget spinners that do vital signs or what have you. Anybody?
You know, one of the devices we used at Mount Sinai, we used the Massimo wireless vital sign machines, and we were able to continuously monitor patients' pulse ox while they were in the COVID rooms. And that was, it's amazing. So you could just walk down the hallway and quickly look at everybody's pulse ox, and you could see very quickly if somebody was deteriorating, you know?
Okay, it's wonderful. Wonderful. And this is the result of, I guess this was sort of accelerated as a result of the pandemic, right? This is not something that was commonplace beforehand.
No, we got them in for the pandemic, and, you know, we had to educate all the nurses on how to use it and set it up, and then that was it.
Mm-hmm. Okay, wonderful. Thank you. Thank you very much. Thank you very much for that. Okay, so anybody else on wearables, whether personally or professionally? Okay, so the next question I'll direct first to Christine, and then open it up to the panel. So what are some of the innovative opportunities used to overcome communication barriers between healthcare professionals, patients, and their caregivers during the height of the pandemic and beyond?
Sure. So thank you for that question. I think that, first of all, that the COVID-19 and the adoption of innovation has allowed for communication barriers to be bridged in unconventional ways. There's no dispute in that. But taking a step back for a second and thinking about the communities that I work with and the organizations that I've worked with in the midst of the pandemic, where there were things such as, or communication gaps as simple as not having, for example, LEP patients, so patients with limited English proficiency, where they were not allowed to bring their caregivers in. And so from a translation standpoint, there was no guarantee of knowing whether or not those patients were given the appropriate information, the right information, and were able to make informed consent decisions appropriately. And so those are some very basic things where we see those structures were not there. We know that FQHCs, those centers have translators, but it's not exactly known that it's across the board that every patient that didn't speak English was given the quality of service that they deserved. And so on the flip side of that, being a technology startup that focus on communication barriers, we're seeing this great adoption, but then also there is, if you're an earlier stage startup, there's hesitancy on that front. So the more mature the companies are, the easier it is for healthcare organizations, so to speak. It seems as though that they're working with those companies, and as opposed to earlier companies. And what I've learned from speaking with healthcare providers is that one of the problem is the issue of funding. So we've seen a significant loss in terms of profitability across, especially New York State. And so that is where there was funding before to bring on new pilot programs and things like that to bridge some of these communication gaps in other areas in innovation. That funding is sort of cut back, so there's more limitation on that end.
Okay, wonderful, wonderful. Thank you very much for your perspective on that. And just would anybody else like to opine on innovative opportunities used to overcome communication barriers? I know Dr. Mike had mentioned something about that. But anything about overcoming communication barriers? Anybody?
I can give a public health perspective on that. I know it was about patients and providers, but you know the public health equivalent is the community conversation, and never has this been more important. By the way, I never realized that comms was the most important division in the health department, but clearly it is. And you know I say that in jest, but the truth of it is that this conversation is unfolding minute by minute, and we have to be better and better at capturing it. You know, our commissioner, Dr. Allison Arwadi, you know, I appreciate Dr. Mike is a social media star. Dr. Arwadi's my social media star. She gets out there. We have Ask Dr. Arwadi, where she takes questions from all comers, and we do a lot of hyper-local social media. And the challenge here is, how do we capture the community conversation, right? How do we turn that community conversation into knowledge? If we were in a hospital, I would say, well, how do we capture unstructured data into structured data and turn it into codes and whatnot? Well, what's the public health equivalent of that? How do I turn conversations when when someone asks Dr. Arwadi about, is the vaccine safe, or who's this person calling to trace me as a contact, they're getting at issues of, thorny issues like trust and safety and security, right? And so our ontologies and our terminologies do not fit this model. And so we've had to learn to build, to extract, codify and build ontologies and terminologies that support our comms team in such a way that turn around that community conversation. And this is multifactorial. It's social, it's behavioral, it's medical. If we find that we do Facebook, but let's just say the Facebook channel, the trust is coming up, we need to be able to structure the concept of trust and fold that concept throughout, our comms across the board evenly, right? And if we can, target it to those places. So that's just one example, but turning the community conversation into computable knowledge is one of the biggest challenges we have as a health department. And it's something that I've just learned in the last couple months.
And I think to Nicholas's point, Keith, there's something called health literacy that is out there. And I think that's the issue of why Dr. Mike and everybody that's out there on social media is breaking down. Health literacy shows that the average health literacy content is written at a 10th grade reading level, where the average over 50% of Americans only can read to a 5th grade reading level. And when you look at people who are on Medicaid, they can't read at any reading level. So what we've been doing for most of our time of translating really complicated health information is, hey, let's put together a piece of paper that somebody might have the opportunity to actually print out or put it on a highly complex website. And the truth is that information cannot be consumed by the vast majority of Americans. So if we start to address health literacy and being able to actually reach consumers in the ways that they can comprehend the information which is being shared, it starts with us as those in the clinical side of doing a better job learning how to translate information that can actually be accessible, but more importantly, adaptable and actionable in a language and in a way that can actually drive outcomes. So if we want to know, why does the general public not trust us when it gives us information and suddenly is turning to social media? It's because those people on social media made it very simple for them to buy the misinformation that they were selling. And for us in healthcare to be really effective, we need to start delivering the same exact message, making it again about us being trusted, and therefore relating it so that people can actually understand it. And that has been the failure for healthcare for a very long time. And if anything, this pandemic has showed us that opportunity right now to prevent misinformation from happening means that we no longer can speak within our own bubbles, but we have to speak to the common layman person on the street.
Okay, well, that's quite inspiring, and certainly hopefully a message that our audience will take forward, because we could really use all the help that we can get. So there's something that popped by in the chat about language. So just anecdotally, today I helped, there was an immigrant who didn't speak English, and I helped the person secure an appointment for his vaccine. And when I was on there, I saw it said, which language do you speak? And I was able to select a different language. That's something that didn't really exist when people were at the stage where people were willing to crawl over broken glass to get to a vaccine appointment. And now it exists, right? So we're talking about disparities, right? And in New York, and it's not unique to New York, but in New York, it's really like the United Nations. We have many people who speak many languages, and a good many people that don't have proficiency in English. So would anybody like to speak at all about language? Because that's something that popped in, and that's something that's really relevant when we're talking about healthcare disparities, excuse me. Anybody at all?
I work
Yes.
at a community health center where I would say 50–60% of my population doesn't speak English as their first language. And in my training, always had access to interpreters via a translator phone, where there's two sides of like a wired telephone, and the patient can hold one side and I can hold another. While that was tremendously useful and gave us a lot of more access and reach to be able to communicate with our patients, now we've sort of upgraded technology to be iPad driven, where the interpreter is visualizing the patient and the patient can visualize the interpreter. We still try and keep this in a more humane way, where the interpreter would be behind me. So it's still myself interacting with the patient and the interpreter is behind me. But the visual component adds such a key layer to that human communication, because a lot of our communication, being a clinician, I understand, is nonverbal. And that's why doing the telephone thing is definitely a step up and an upgrade. Having the visualization aspect adds another layer of improvement to that doctor-patient relationship, where you could pick up subtle cues. You could understand that the patient may not understand or may not grasp exactly what's going on. And to me, I don't know if the other providers here have had the same experience, but that visual iPad interpretation system has gone really a long way to improving patient satisfaction and outcomes.
And it's not just about verbal communication. It's also the written communication. You know, you can, educate a patient before they go home with an interpreter, but when they get home, maybe they forgot what you said and they have to look at their discharge summary and it's in English. We have a long ways to go to change all that language to, accommodate our patients.
Yeah, and if
More
I could
work
just,
to be done there.
if I could just add throughout, sorry to step on that, Kelly, but if I could just add that throughout the pandemic, one group of people that I have my admiration has grown by leaps and bounds are sign language, the sign language interpreters that have to stand next to those governors and mayors and commissioners and sort out some of the most complex, complicated, emerging concepts and language. Sometimes it's controversial. I just wanted to give a shout out to all the sign language interpreters that are out there that every day get up and do those press conferences. There's always, and I actually did get to do a press conference, and so I got to actually to thank them personally. And I just find that everyone remarks at how they appreciate their work and how hard they actually work every day. So I just wanted to say that, shout out.
Okay, well, wonderful. I'm sure they appreciate it. So thank you very much for that. I too have great admiration for them, and some of them are quite dynamic. Okay, great. So, anything else about language related to health literacy barriers, etc.?
Keith, if I may add, I know that I wasn't going to speak, but it really speaks to me because again, as someone with the background whose English is not the primary language, and so I just wanted to mention that it's truly amazing how far we've gone with translation and interpretations actually in the hospital setting as well, because in the past, very often you would see a family member doing this work. And now we see, actual interpreters doing the work. So we've really come a long way. So that's the great news. And another thing I wanted to mention is accessibility, which has now become even more important, because then when we're online in a virtual environment, we now have to make sure all of the documents and all of everything that we present is adapted to being accessible to all different populations. And so just wanted to chime in on that. Thank you.
Wonderful. Always a pleasure. Always a pleasure. So the next question, we have a pile of questions in our chat that we have to get to, but the next question is regarding application development. So this is first to Nicholas, but it could be really to anybody because I could see how this could traverse multiple panelists. What makes application development so hard for health departments in this time of COVID? And I just want to give a little bit of a different angle on that. Is one of the things that we're seeing related to internships is sort of a difficulty in finding student placement for internships. And we also see a job market that's quite dynamic, that's quite soaring, and there's really quite a demand out there. But in that context, what makes application development so hard for health departments in this time of COVID? For Dr. Nicholas.
Sure. Sure. Thanks for that question, Keith. And this is anyone that's running COVID operations right now has this issue where we are not software development shops. Traditionally, we're very vendor-based, contract-based. And so now, even if we have our skillful contracted vendors, we are now in 24-hour development cycles where our contact tracing platform, our vaccine operations platform, whatever your various mobile device, mobile platforms that you're using to communicate with the public, where today's problem needs to be fixed today. Right. So we've never operated at this speed. We have some excellent partners, top-notch firms that everyone has heard of. And we're having to do an entire sprint in 8 hours, which means massive parallelization of groups, right? So whereas maybe your PM was also would also run your group interviews or your requirements gathering sessions or whatever it is. Now everything has to run in parallel and be ready by noon, and then we're testing by 1, right? So I think number one, the timeframes have never been seen before. So you have to also quickly requirements gather, meaning that you have to be able to work with your clinical units almost instantly, and they have to be ready to be worked with. So it just really requires, part of the complexity here is really just the compressed time frame and the unexpectedness of all of it. And we're all on we have a year to build a software program, that's just fantastic. But if the Vaccine Operations Center, at 11 o'clock at night realizes there's a problem with our eligibility criteria in our platform, so no one can register, that means that people that have never developed software now have to get really good at developing software in, several hours. So I just think that it's a new skill set for health departments. Even with the greatest of partners, you still need the informatics team as interpreters, as project managers, as movers, even movers of paperwork, frankly, to procure and to contract your vendors. You may not have enough time for legal to figure it out, and you might seriously just need an informatics person to translate to the lawyers so that they can get the paper between you. So I found that that you need informatics at nearly every juncture as translators, because that domain knowledge that they have that you need has to come both ways to the vendor. So I'll just stop there. I think that was kind of rambling, so please ask questions.
No, that actually is very useful information that and a perspective that we really appreciate, because your audience members are consumers. So they may not be from Chicago, they may be from New York, they may be from other large metropolitan or rural suburban areas, but ultimately we're using a website to, and the technology is involved in getting that coveted shot, in being involved in contact tracing, in testing, right? So we've all experienced our frustrations trying to use the technology, being on the other end of it. Some of us, like myself, I was involved in vaccinating early on and got to see some of the trials and tribulations and some of the rather frustrated people walking in the door with really, really high anxiety as a result of some of the processes they had to deal with. They were fine, by the way, once they got there, the sites themselves. But I think that's really interesting to give the perspective from you as a provider of this and having to work in such a compressed time frame. And I know that when you have to put together these projects, there's a certain amount of QA, perhaps piloting and testing and what have you, and maybe perhaps a lot lower risk than suddenly having to put something together that millions of people will need suddenly at once in a compressed time frame without having gone through the rigors of testing or the time that it takes for testing. So I really do appreciate that you shared that perspective with us. Does anybody else want to speak about either your experience with or your knowledge of with patients, using this technology, some of the trials, the tribulations, or maybe some of the development that's gone into things for either the treatment, testing, or somehow involved with the pandemic?
So I still think, Keith, that one of the biggest issues that are facing healthcare today is the interoperability with access to information within EHRs. That did not change in this entire one. And why that's important is when you're dealing with a pandemic, access to real world evidence as it's going on is critical to being able to solve that. And still we sit with the situation of the interoperability of being able to do that. Now, what we did see was that Medicare did roll back rules that actually suspended the use of EHR documentations in wide scales. And I just saw a great note by Stacy where things happened faster in COVID. As I've said, but many people smarter than me said that, more changed in the first 8 weeks of this pandemic than we had seen change in decades. The status quo, the protocols, the procedures that we had followed were thrown out the window because they did not meet the needs of what we needed. And what did not fall, unfortunately, though, was the lack of API integrations among large-scale platforms that could have potentially helped us even dealt with this crisis better. In the United States, we've lost almost 600,000 people, and still we could not translate this data across platforms easily to actually address care issues. And the only major integration that you actually saw happen in the world of EHRs was a partnership between Microsoft and Epic to actually deal with telehealth issues. Now, why in that era, when many other institutions were coming to get together and get access to better data, why that wasn't forced into the hand to sit there and say, look, if there was a time to do anything to allow greater access to information and data to be actionable, this was the time in which I think that we have perhaps failed the American people to push forward the issue of interoperability, to drive greater possibilities so that app development, data collections, and actionable information could be translated into systems. And I think that, to me, is still one of the fundamental elephants in the room that needs to be addressed. And basically, our public health system should be demanding. The truth is we're dealing with patient lives here, and public health should not be an issue about money. It should be an issue about access.
Okay, wonderful.
Can I just respond to that, because I feel like there was a natural segue there. One of the things that I'm most excited about, I find real promise in e-case reporting and the initiative around e-case reporting. And you know, I've been around public health for a while, so there's always a lot of promise. But I do find that we have the best chance of success I have seen to date now around e-case reporting. And for those of you who don't know, if you're using an EMR at your practice, your FQHC, your community hospital, there's trigger criteria that can be defined at a central knowledge base, federally, in fact, and those triggers can be pushed out to electronic health records in a EMR vendor mediated way, meaning that the CDC has set it up to work with vendors so that widespread e-case reporting, so vendors with large penetration in the market can turn on e-case reporting for their provider community, or customers, I should say. And so e-case reporting is one place where I think that better interoperability and EMR integration is really going to benefit us. And that doesn't just have to be COVID. That can be STDs, that can be TB, it can be many, many things. And again, it's not just the technology and it's not just the data. The programs that will be propelled by having e-case reporting at the point of care, I think will also be, can be much more robust than what we have now.
Okay, fantastic, fantastic. And anybody else on our panel? Okay, so we can go on, because you guys have our wealth of information, and it's quite riveting. However, we're at the top of the hour now, so I would just, and we do have a pile of questions that popped into the chat, some of which we've covered, others of which I think are rather engaging. So you know, perhaps we can go through some of those. I don't know if Olga wants to mention them or if I could bring them up. Either way.
Whichever you prefer.
Well, yeah, if you'd like to address some of, there's some jewels out there, I'd appreciate it.
Sounds good. All right. So we have actually a number of good questions here. One is from one of the audience members. And how does informatics and AI-based translation works across meeting needs of cultural competence? Research recommends culturally sensitive treatment to improve patient satisfaction outcomes. Anyone in particular would like to start us off on this one? And informatics and AI-based translation. And are we meeting our cultural competence? I think we touched a little bit on that before.
Yeah, I think we did.
Yeah, I think this is AI based. It's almost looking to the future of how we, you know, we already have, I think, Google Translate, and it's still not as accurate as we want it to be.
I'll jump in. It's
yeah.
Okay. I can jump in.
Yeah.
So I think that anyone that knows my particular brand of informatics knows that I need people to do my informatics, right? That without people, there is no informatics. And so when we talk about AI translation, and so, the logical conclusion of that is that you can't have technology without people, meaning no autonomous, right, intelligence. So when you talk about AI translation, I move it back to AI tools for translators, which make them better achieve their translating objectives, better service for their clients, better service for their employers. So I don't think that AI translation is ready yet, but I do think that we could do a much better job at providing AI tools to translators that then go on to do their translation job, right? So that's my wrinkle on that. And you can do that for almost any AI tool, is if you move the AI back to a support for the user, it becomes a lot more practical and possible today than some far off future where machines win and maybe the jetpacks, Keith.
There's a related question that has to do also with the HIPAA compliance when it comes to translations. So how do you think technology, when it comes to technology translation specifically, may relate to that? So I just wanted to throw it out there.
And the other part of the question is basically a comfort, right? So if you're thinking about, I don't know, a psychiatrist's office or something that's a little bit sensitive information, because I think HIPAA and the rules that came after it, I think pretty much cover the translator, right? So that's, I don't want to shortcut the answer, but what about the sense of comfort or discomfort that might go along with the translation services?
I think that's why it's so important to have the human component of seeing another human's face when communicating about health issues. Also, my experience has been when I initially connect the interpreter with the patient, their introduction, it right away states that anything you said will be kept confidential. I'm here to only act as a bridge of communication between you and your physician or other healthcare practitioners. So for me, the experience with patients has been more comfort despite another person being in a room, simply because they've had so much trouble communicating with providers in the past.
And I'll just jump in here and I'll say that we're using natural language processing to help patients document their symptoms outside of the clinical encounter. So some of that unstructured data, using that technology, having it all be HIPAA compliant, because it's just easier these days to do so. But again, going back to that cultural competency piece, that I believe comes from the providers and the administrators ensuring that the people at the front lines are culturally competent, that they're able to deliver care without bias, without discrimination towards the people that are coming in. And so there has to be a system of checks and balances to ensure that that cultural competency piece is met outside of the technology.
Absolutely. Absolutely. So if I could just go back a little bit to health literacy, right? So we were talking about health literacy, meeting people where they are, being able to describe things in terms, right? We mentioned the 10th grade reading level versus the 5th grade reading level. And so just one of our audience members asked us about something that we were talking about, wanted to describe what the cloud is, right? Because we mentioned about moving everything to the cloud. And so they were expecting some sort of precipitation. But with that in mind, maybe we could discuss, or someone, if they'd like to basically say, what is the cloud as it relates to healthcare informatics, and how are we using that, these cloud technology in the age of COVID? And I guess this question was originally for Nicholas, but anyone.
I think I'm the guilty party. I said cloud. I'm happy to yield to anyone else that wants to talk about clouds. I'm not a weatherman. I do love a good rain slicker though. No, so it's a really good question. I mean, I think that traditionally municipal health departments have struggled for resources, older buildings, older infrastructure. This can relate to wiring, wire closets, servers, racked servers, server rooms. And I think that that's what we're used to, that I wonder how many of us have a P drive mapped on our laptop, right? And we just know that we put the laptop in its dock, a couple things happen, and now I'm attached to a P drive that's somewhere on my campus, that I can get to. We just all trust it. The cloud really isn't any different. It's really just a set of computers that are elsewhere. What you don't know, though, is that how they're arranged, how they're organized, how the redundancies work. And so, cloud has essentially become a supercomputer, meaning super in that you can connect many computers to look like one. And that's what we do. We've replaced our what's called on-premise computing, meaning things in racks, with things in the cloud, because companies like Amazon Web Services, Google Cloud Platform, Microsoft Azure, they offer redundancy. And again, a cloud model is beneficial because another reason, or I shouldn't say again, but another reason why a cloud model is beneficial is you're paying for what you use. So when we have, and you use it when you want to use it. So when we have a giant file come, hey, you have to match these negative tests to this entire, employer's, role or whatever, we can spin that up very quickly. We will pay for whatever it costs for us to run that analysis, and then we shut it down, right? And so in our mind, the accounting becomes a lot easier as well in a cloud, where you can budget for the real cost of processing your data. So the cloud is essentially just a collection of computers that are elsewhere that can fail over to each other. And the other thing I would say about the cloud is it's always drawn as an actual cloud in the Visio or PowerPoint or whatever. It's nice because think of it, it also can take lots of connections, and modern architectures are allowing us now to exchange data from the NIH's cloud, NCI's cloud, the CDC's cloud. And now we can all talk to each other with multiple connections, and we don't have to be hardwired or on the same VPN. We have protocols and standards that not only secure data transfer, from within jurisdictions, but among federal partners as well.
And imagine with so many of us working from home, people are using cloud technology perhaps without even realizing that they were doing it.
Absolutely. Zoom is a cloud technology.
Yeah. So for those of you wondering if you're using cloud technology, I guess if you're using Gmail, if you're using Hotmail, Outlook, if you're using one of the photo services on your phone and you're able to see it on your iPad or your computer, you're using the cloud. Okay, wonderful. Thank you very much. So that helps out with our health literacy portion. Olga, are there any other questions from the panelists that that we should address?
I think we asked most of them, but there is one just coming in. It's still coming in. Okay, let's see. Can anyone detail the issues of spam, spyware related to medicine and telehealth, especially during COVID? And I think we have a couple of experts here who can answer that question.
All about disinformation. So thank you so much. Anybody?
Keith, I thought of you, but Rebecca can chime in.
Oh, it was directed. No, not. I'm just the moderator here. I'll direct it to our talented experts. I'm going
to let the experts speak on where this and the spyware and everything that's happening is. Obviously, this is a major concern in the hospitals, and having anybody on a Bluetooth device potentially be hacked. But in the earliest days when COVID started to hit and our organization started to hear from nurses around the country and everything was falling down, we started to do weekly meetups with nurses from around the United States, heading into their shift, leaving their shift, on their shift, because everything that they were doing was failing them that they thought they could do. So suddenly we brought together these groups of nurses who everything that they thought that they knew at the bedside was wrong. And they were saying, hey, watch for a CO2 level on, as it starts to approach this level. Your pulse ox, they're going to walk in talking and laughing and their pulse ox is going to be at 70. You're going to be intubating them within 30 minutes on this time. Flip a patient over onto their stomach. I know it doesn't make sense, but it's working for us. And suddenly this communication of nurses calling in from around the world, calling in to say, how can we support each other when there was no information? Because, right, we used to go to journals and research and everything was evidence-based practice, but in the era of COVID, we couldn't go to evidence-based practice. So we started to host these events in March, and then all of a sudden April was turning up, and I said, you know what we need to do is we need a place where people can come together and innovate very safely. And we reached out to Microsoft and J&J and asked if they would host a hackathon for nurses who were on the front lines of these crises, because we didn't know how they could scale these ideas up. And we were really lucky that in 6 weeks' time, Microsoft turned over their platform for us and we supported it. And hundreds of nurses came together, actually thousands from around the world, to talk about these ideas. And I think if there was one thing that became very apparent to me, was that access to humans on the front line and face-to-face interaction was absolutely critical of sharing information in a meaningful way, but could be bounced off ideas with each other and dealing with experts in the field who could actually solve those problems. So if you hadn't seen, Microsoft put out an article just recently, their CEO, who said during the pandemic, they created over 700,000 innovators because they kept hacking in their own place to make sure that their technology was meeting the needs of their healthcare professionals on the front line. And I think if there is something really critical to take away from this pandemic, it was that for those organizations who leaned in, those who challenged the status quo, who worked to get their processes to be better, they had huge success driving outcomes. And it was for those who waited and sat back and kept operating business the way they always had. They struggled, and I'm not sure that they are going to catch up in those times. So I think that there is a real lesson here to be watched and to study, which is how do we develop technology in the era of a pandemic that rapidly needs the front lines communication and keeps people safe? Because the truth is, those big technology companies, they do have the technology, they do have the infrastructure to create great solutions if they were engaging with those on the front lines and were willing to work with them.
Wonderful. Thank you very much. And I'd implore people to get involved in some of those endeavors. Absolutely. So thank you very much for that. I also just want to mention that that when you're speaking about hacking and your hackathon, a lot of people tend to think, at least in popular culture, of the hooded figure sitting there in a dark room drinking Mountain Dew and kind of doing all kinds of nefarious things. And right. But this is actually more of a positive spin on. This is more innovative, creative, inventive things that rising to the occasion where that there's a need, there's an invention, and some of these things could be simple, some of these things could be rather complex. Because I think originally the question was about hacking. And so you turned it into something that's quite positive, just like when we look at social engineering, it could be very, very positive. So thank you very much for that.
And I think the question, Keith, comes back to spyware and how do we prevent that from intubate? I think everybody's concerned about if you have an implant that's managing your heart rate, if all of a sudden there was a spyware that was implanted into that and totally took over and sent everybody into dysrhythmia. And I know that right now, and you should speak to this, Kelly, but when we were starting to do remote vital sign machines and pulse oxes, there was a lot of concern in hospital systems. Could we actually use Bluetooth without it doing it? So suddenly medications aren't being administered at 1,000 milliliters per hour because somebody hacked into the IV system and changed that delivery of medication because so much was being done remote. But can you tell us how your health system's managing that at Mount Sinai? Because they're really ahead of this in addressing some of that.
About the Bluetooth?
About how you're protecting, you guys adopted this so that basically spyware or that hacking into these systems kept patients safe. Like, how do you guys keep this remote patient monitoring system safe from basically somebody hacking in and like what they've done to bank accounts, wiping your bank account clean so they don't take control of the IV pumps or things like that?
I actually don't know the best answer for this, to be honest with you, Rebecca, but I know, our IT, we have a very large IT security, and they're very vigilant about always checking the computers, always rebooting them. They send out tests to make sure people won't, click the link. So our security is very good.
Yeah, I could actually speak to it, but I don't really want to speak too much. But typically an operation like Mount Sinai or any really operation worth its weight in salt typically has a security apparatus that looks at multitudes of different things, some of which might be more innovative than others. But certainly it's all about risk reduction, right? And the more that we're dependent on these medical devices, the more that we're dependent on these electronic systems, the cloud and what have you, certainly that changes the risk.
And I think that's one of the reasons I think, Keith, at the beginning, we were trying to figure out how to, monitor these patients. And one of the ideas was baby monitors, but that's not very secure. So we said we couldn't do that. That's why we worked with Google and Amazon to get the Google Nest and the Amazon Echoes, because it was more secure.
And it seems to me almost anecdotally that a lot of this ransomware and if people aren't aware of that, I encourage you even, just to look into that. But even like it seems like there was a dip in ransomware, at least from my perspective, and it almost seemed like those nefarious agents at the run up at the original part of the pandemic sort of took like a hands-off approach, because it really crosses the line when it's one thing to rob a bank, it's one thing to hold a company for ransom, it's another thing to dismantle the operations of a hospital to the point where it affects patient care. And then so they kind of gave us a bit of a pass for a while, and it seems like they're back in action. And that might have been a little bit about what the person was talking about. But thank you very much for that. Anybody else want to opine on cybersecurity, or some of the disinformation? There was all kinds of scams going around about, still are about COVID shots, getting appointments, and all kinds of.
I would put a spin on that, Keith. I'll just make a comment. I don't really have an answer, to be honest, but whether it's as simple as the contact tracers, if the phone number doesn't say state health department, local health department, a lot of people won't pick up the phone, right? Because they've received so many phone calls that are, I'm still getting a phone call about insurance for a car from 12 years ago. We all get spam and we're disinclined to answer our phone. And the real cost of it's just trust in our public health infrastructure, that when someone tries to scam to a vaccine appointment when they know they're not eligible, and so they take their loved one to that, point of dispensing, and the person can't actually get their shot. Well, of course they feel disenfranchised. Of course they feel distrustful of the public health system. So, the real cost of all of the disinformation is the erosion of trust, which is the most important thing for us to get out of COVID. And so, improving, unfortunately, security is so critically important for us to get out of where we are now, because without that trust, we will never have a population that is willing to make the sacrifices required for us to, finally have a barbecue again, or a real happy hour.
Right.
Which actually,
Keith,
I'm sorry, there's another question which I think sort of, I don't know if we have one answer for this specifically, but I think we probably could throw a few ideas out. And this is in terms of how do we as healthcare providers convey medical information to uneducated people, especially in these times when rumors and misinformation are all over the internet. And so I just feel like, there's definitely a lot of work to be done in the future. And maybe this is something that we all collectively can chime in terms of what we think might work. And I know Dr. Mike already mentioned a little bit about the social media, but I think we can certainly elaborate more.
I think you always have to make sure you refer them to those, websites like the CDC and, real websites and real people.
Authoritative sources.
Yeah.
So I would chime in that I think that might be part of the problem, is that always sending people to authoritative sources that don't speak to them in a language that they understand or in a communication way that they understand is half the problem that we're dealing with. And I think there also was a substantial amount of damage done to what happened to the CDC and the reporting structure in the course of this pandemic that further eroded confidence in organizational institutions. And I'm not an expert in this, but I think just from the perception of what is going on out there, how do you combat the amount of misinformation that exists in the world when they don't trust what we can say authoritative sources? So actually, Dr. Mike, I know you have a huge following in this area, and there's a couple of those that have been out there, and they're calling it head on head, right? They're going head to head with people that are providing that misinformation. And I'm not sure if we need to be more aggressive on those social media platforms, putting out a lot more providers who are relatable and actually calling out the individuals who are out there repeatedly saying it. So how do you think we can address the issue of social media misinformation, as opposed to just pointing back to sources we know people aren't going to go look at in the vast majority of way anyway? So what do you think?
I think it needs to be done strategically because, for example, you'll have medical professionals go on and start debunking individuals who are so extreme outliers on that end, where they're giving maybe some single dozen individuals bad advice. And while obviously anyone hearing bad advice is problematic, but by bringing that person and critiquing them on a very large channel, like let's say my own, you're actually adding fuel to that fire to some degree, because now you're having people wanting to hear the other side and you're giving them a platform. And then on the other side of things, if you have an individual who's created a video that's gone viral already, that's absolutely a time to act for healthcare professionals to do response videos, to present the accurate side of that picture. And a big part of that strategy lies in the collaboration between institutions like the CDC, the UN, WHO, with people who are doing this quite well. I just had a partnership with UNICEF talking on 4 different levels of how the COVID-19 vaccine works, one to a child, one to a mother who recently gave birth to a beautiful baby boy, a PhD student, and then the chief immunization expert for UNICEF. And it shows that you can have that conversation on 4 different levels, talking about the same thing, but achieving different goals based on people's health literacy. And I think when I go and speak on social media or on television, speaking about COVID-19, we try and do it in a level as if I'm talking to the 8-year-old. Not because I'm trying to talk down to individuals, just because people are getting so much information so quickly that even if they can read or understand on a 10th or 12th grade level, it takes a little time to process it, and they may lose interest in it because at the end of the day, science is not the most interesting for everybody. So if you could package it in a way that's relatable and fun and easy to understand, it makes it that much more effective.
And I'll just jump in right here and say, I think transparency is very important. Earlier, one of the panelists, she just said, I don't have the answer to that. And I think that builds trust as opposed to not being transparent. Another piece of that is credibility. So not only sourcing where, not only listing the sources of where the information, credible sources, so to speak, but also having people at the community level. So I respect the doctors. I love that they have a voice in social media, great. But we also have to have those community leaders that can reach those vulnerable populations, because chances are they're willing to listen and digest that information. And again, going back to what Dr. Mike just said about the literacy level, assume that everyone is at the 5th grade level. That's the advice that I got when we started building our technology to really reach those underserved population. And I think consistent information about existing scams, debunking those false information that might be out, educating the public on not clicking on links that are not from credible sources, et cetera. And I think those are some things that can be done.
Wonderful. Well, thank you so much. So we're, as much as I'd like to go on, I could talk to you guys for hours. You guys are really rock stars. We're coming to a close. So there's one question that was just, it kind of pulls at my heartstrings, that if you'd be so kind as to entertain me letting you ask this. And then perhaps if you guys have like a quick, maybe 30 seconds, just any final thoughts after that. So you can think of this while I'm asking. But there was a question that was directed to a single individual, but I'm going to pose it to anybody that really wants to answer it, is that you've all had to juggle multiple things, right? So in addition to, we all have complicated lives, right? We have lots of things going on. We have work, family, and then COVID hit. And then you're doing multiple things. Some of you have YouTube channels. Some of you are doing hackathons. Some of you have your own companies. Some of you are, for example, a nurse manager for Informatics during the height of COVID and everything that goes with it, or the Department of Health. You've all had to do quite spectacular things in the midst of COVID. So the question was, how do you balance your lives? So the question that really came from this person is, sort of, how are you all doing? How did you manage to balance your lives during COVID with all of these complex, sort of innovative informatics types of things going on? Anybody?
I think just like our patients, we're all struggling. I think healthcare providers in general have faced a very heavy brunt during this pandemic. This goes for all essential workers as well, but healthcare workers working on the front lines have taken a burden with more information being given to us, less resources, less abilities to see our patients and be with them in person, or even if you are in person, you're wearing masks and the communication struggles make it even harder. My thing that I've relied on heavily has been empathy. Exactly what you said in saying, imagine all the things that you've gone through as a person. I try and think about those things for my patients. So in delivering good medical care as a DO, I try and think as holistically as possible in understanding that when I tell a patient, okay, and everything else that's going on in your life. Now you need to go to physical therapy 3 times a week. And then I also like you to see the nutritionist and do X and Y and Z, and then go shopping at this specific health food store that's really far away from you for fresh produce. I have to think how reasonable that is, keeping in mind all the struggles that I have. Because at the end of the day, we might be, information specialists, doctors, nurses, we're all humans. And the more we can bring everything back to that level of empathy and realizing that we're all humans, I think that's the way we deal with things. That's the way we deliver better care. And I'm sure Dr. Nicholas can even speak to the informatics component to this, how he mentioned earlier that he believes that he needs humans more so than AI when it comes to creation of some of these applications and usages.
Okay, thank you very much for your perspective. We really are all.
Did we lose Keith?
We lost you, Keith.
Yeah, I think
Okay.
he wanted, Keith, are you back?
I'm back. So let me just ask you this. Why don't we have a final wrap up where, and you could feel free to include that in your, the how are you doing in the final wrap up. But how about if you just say maybe a quick 30 seconds, sort of anything that comes to mind kind of as a bookend. And so I see we have Kelly, if you'd like to go first.
So I would like to say, everyone focuses on the nurses and the doctors on the front line, and I don't think we could have gone through this pandemic without our IT department. So they are the unsung heroes of this pandemic. Because of them, we were able to have fathers in the delivery room with their wives or, significant others. Families were able to see their loved ones while they were in the hospital. We were able to build surge units overnight. Put them up. We were able to put up our vaccination pods overnight because of IT. So, big shout out to those folks. And I'm doing okay. I just get up every day and do what I need to do.
Wonderful. Thank you for doing everything that you do. Okay, and anybody else, any final thoughts before we wrap things up?
Sure. I would just like to say, informatics is a social science. And I've heard many times over the last however many months, wow, you're sort of like a psychological counselor. And it's true, because the anxiety that technology causes us and the cost of getting it wrong or a data breach or a hack we lose context that our colleagues don't know what we know. I tell my students, you're the informatics dude. Someone's going to come to you for answers, and you have to confidently answer and be an informatics professional. And so just recognizing that informatics is a social scientist, and that the two best tools of any informatics scientists are listening to people talk about their problems and watching processes live. And that your powers of listening and observation have not gone away, whether you're on Zoom, whether you're in the operations center, wherever you are, and that we need to double down and diffuse the tension that technology and all this data cause, and recognize that our colleagues need us as a source of comfort occasionally. And I can see this in people's face, and it is not something I knew I had in my informatics toolbox. But I've really learned to benefit from, and I think that it does add value.
Wonderful, wonderful.
Thank you so much. Could wrap up, Keith. I think that what people might not be aware of is how much pressure the nursing profession has been under, and that in 2020 we faced the largest exodus from the profession in U.S. history, and that the number of nurses looking to leave the profession is through the roof. Now, for decades, we knew these problems were coming, and they have been multiplied. And if you look at the research, nurses on average do 27 workarounds a shift. They are in 36 different places in the course of an hour. They are innovating in highly inefficient places, but their profession has such downward pressure on it without that ability to interact. And one thing that COVID did allow to happen was an interoperability among professions to come together and work and collaborate and break down barriers of the hierarchical systems that exist in healthcare. And if there is one profession that I am petrified is going to be potentially far less in the future than it is today, it is the nursing profession. So I'm going to ask all of you that if you have a nurse in your family, please thank them for what they've done. And if you want to help some of these nurses, we're doing an event on May 14th through the 16th called Nurse Hack for Health, which is basically asking any nurse who has had an issue on the front lines of COVID, who want to address that challenge, to come forward and put this problem forward and create a solution so they can be heard. Because what we've seen is that these ideas coming from nurses on the front lines not just solve small problems, but they solve major problems that impact human health and suffering. So nursehackforhealth.org. We'd love to see you more May 15th through the 16th, because if you want to help nurses transform the future of healthcare, we need you to show up and participate and support us. So thank you.
Wonderful, wonderful. I encourage everybody to support your endeavor and all of the other endeavors.
Looks like we're losing Keith again. Keith, we are not able to hear you.
Okay, how about now?
Yes, thank you.
All right, so talk about technology, right? So I'd implore all of you to go to the NYAM website or look in your email. You see the list of names of everybody, and look through their LinkedIns. You can get linked into them, and you can see everything that they're involved in, you know, and you might be able to.
Okay. So, anybody else have any final thoughts before we wrap things up?
I think I have a word to say, which is that technology in itself is useless if it's not meeting the needs of the most vulnerable people in our country and the people that care for them. And those are my last words.
Words to live by. Words to live by. Ironically, the year 2020 is the year of the nurse. So what a year we've had, right?
And it continued into 2021. It's still the year of the nurse.
Is it? Okay.
We get 2 years.
Extended.
2 years. Wonderful. Wonderful. Yeah. They couldn't give us 2018, right? Okay. Wonderful. Wonderful. So
I do want to thank our panelists, and I do want to thank Dr. Mike for always supporting nurses, because I've seen his content and supporting nurses. So shout out to you, Dr. Mike. And it was a pleasure to meet Dr. Nicholas too, and see the wonderful work that you've been doing. And Rebecca, thank you so much for the plug-in on the Nurse Hack for Health. Yeah. I do hope that people will join and help healthcare solutions come to life. And then Kelly, again, our New York representative here. So thank you so much. And Keith, it was a pleasure to meet you. So thank you, Keith. And I'll transfer it back to Keith and for closing remarks. Thank you.
My closing remarks were just to thank everyone. So you've taken care of that so wonderfully. So Rebecca Love, Christine Monkhouse, Kelly O'Neill, Nicholas Zulakis, Dr. Mike, you guys have all been wonderful. We really do appreciate everything. And my apologies, Dr. Fauci couldn't join us. He had a prior engagement and he couldn't send his stunt double, Brad Pitt. So we'll try to get them for the next one. But really, you guys are rock stars. I really do appreciate it. I just want to thank the audience for joining us. The Informatics group, right? So you see a couple of us up here, but really this is quite a group that we have, people that are really hardworking year after year, without which these events couldn't have happened. Our supporters at NYAM, you know, who have helped us, and our past supporters, and we hope to have you back next year, or hopefully sometime soon in person. Right, so stick with us at NYAM. The food is awesome, and we put on great events every year. We hope to continue that. And please don't forget to go to the NYAM website and sign up for many interesting webinars. And with that, I thank everybody very much for everything, and of course, Olga Kagan for moderating along with me. So you know, this would be the time where everyone would give you guys a round of applause, but it's all virtual. So thank you very much for everything.
And Keith, if we can just stay for one moment, and I'm not sure if Joey or somebody could do a screenshot, or I can try to do that.
I have done a screenshot. I can do another one if you like.
Okay, so.
I don't know if we could all start clapping, and I could take a screenshot of the clapping.
All right.
Awesome. I've taken a few pictures.
Wonderful.
Thank you, Joey.
Okay.
All right. Thank you so much, everyone.
Okay. Thank you,
everyone.
Take care, guys.
Thank you.
Take good care, guys. This
Bye.
is great.
Bye-bye.
Thanks, everybody.
Have a good evening,
Thank
everyone.
you.
Bye.
Bye.
Bye-bye.